Hi, good morning, everybody. This is Tyler Hausman from the Quality Institute. I think we're going to go ahead and get started. Just a housekeeping item. We do have everybody's line muted for any background noise. If you have audio speakers on your computer, you do not also need to be dialed into the conference line. If you're dialed into both, you'll probably have an echo. So if you have audio speakers on your computer, you should be good to hear us through your computer only. So as I mentioned, I am from the Quality Institute. I'm the Senior Director, and I run the QI Collaborative, which has served as the learning network of the Quality Institute since 2011. And with the support of the Nicholson Foundation, we've worked with both the certified and non-certified ACO communities in New Jersey to offer shared learning opportunities and best practices like that you'll hear today. And the Camden Coalition really pioneered this work, and they're offering 2 training sessions to our Quality Institute members to highlight the best and worst practices that they've identified in the areas of care management and data use. So today we're going to hear from Molly Charrington, Camden's clinical manager for the clinical redesign team and ACO operations. She's going to be talking about care management interventions and workflows that they've activated across the Camden ACO, including triage and segmentation, operations, care philosophies, and data. And then we will hear from Natasha Dravid, Camden's Associate Director for Business Systems and Continuous Improvement, on the work of standing up a citywide patient satisfaction survey and how to collect, analyze, and activate the resulting data. So as I mentioned before, just a couple housekeeping items. Everybody's phone line is muted, so if you have those audio speakers on your computer, just jump off the conference line. And if you have any questions during the presentation, please put them into the chat box. We'll be keeping note of everybody's questions and then have a break in between the 2 topics to answer some questions, and then of course some Q&A at the end. And finally, we are recording this webinar for later use. So we'll send the webinar recording as well as a bunch of other materials out to everybody after, and probably have it up on our website as well if you'd like to share it. So without further ado, I'm going to kick things off to Natasha to get us started.
Awesome. Thank you, Tyler. This is Natasha, and before I hand it over to Molly to start talking about our care management initiatives, I just wanted to give a little bit of background about the Camden Coalition ACO. So we were certified in July of 2014, and we're in Camden City, and we work with a community of 3 hospitals. So we have Virtua, Cooper, and Lourdes, Our Lady of Lourdes hospitals. We have 12 primary care practices, and we're working with about 38,000 covered lives. And before we were certified as an ACO, we had 2 contracts in place with the 2 major payers in the region, United Healthcare and Horizon NJ Health. So that's just to set the stage for the work that we'll be talking about today. So I'm going to hand it over to Molly to talk about our care management initiatives.
Hi everybody, my name is Molly Charrington. And in today's overview of our care management initiatives, I hope you'll see that we're continuously working to find the balance between standardization of our protocols for care management and flexibility in order to succeed in the ACO by meeting patients at where they are and at their need in any given moment. I'd like to start with a patient story, and I have de-identified the patient. Anne is a 42-year-old female with a history of IV drug use, cellulitis in both legs, hepatitis C, and a history of various other infections. She has also chronic mental illness in her medical record, documented in her medical record, and a history of trauma and PTSD. She has 7 inpatient admissions, 12 ED visits in the last 6 months, and Anne has experienced homelessness for the last 4 years. We saw her in our data feed, which you'll learn more about soon in our patient selection process, and we met with her in the hospital several times to engage her through our care management intervention during the last 1.5 years. Anytime we met Anne, she said she wanted to work with us, she was interested in our intervention, but we couldn't get her to work with us for more than about 10 minutes at a time. And so we provided her with a phone. She didn't pick up when we called, and she didn't call us very often. We really couldn't get traction with Anne. She's highly visible in Camden because she collects money at a major highway exchange here, so we could see her and talk to her almost every day, but we couldn't engage her meaningfully. So after years of not knowing exactly when to stop working with a patient, in our standard intervention, we developed protocols to guide our health workers. These included that the standard intervention here is 90 days. No one gets in trouble if patients are on the panel longer, and most are, but it serves as a guidepost that this is a short-term targeted intervention to improve access to health care. As our panel size grew, we were required to prioritize our efforts with patients, and we determined that when a patient cannot be engaged after 3 attempts, we enter an outcome for them in our database software and our tracking software, and we stopped working with them at that time and reached that point in our intervention last winter. But 2 months ago, I got a call from a primary care provider in the ACO who used to be Anne's doctor. The provider said Anne was in jail and really wanted to reach out to someone at the Camden Coalition but didn't know how. So I called Anne's social worker in the jail and we arranged to talk. Anne was engageable on the phone with me for 30 minutes. She had a clear plan for herself that she wanted to stop using heroin after being forced through a very uncomfortable withdrawal in the jail. But she said she was scared and she knew that she couldn't do it without help. She apologized to me numerous times on the phone for being, quote, difficult. And I encouraged her that we were just glad she thought of us and that we'd meet her when she was released. We worked with her judge in another county to address a warrant for non-payment in another matter, and this meant a lot to Anne. She had some unmanaged infections, so when she was released, she actually went straight to the ED, borrowed someone's phone, and called us, and I met her there at the ED. Pardon me. So while her medical picture is actually far less complex than some of our patients, Anne does have chronic illness, and she has clear barriers to adequate health care, including homelessness, lack of income, no phone, no ID, and strained relationships with her family. That we were willing to show up when she was ready after a stay in jail proved to be important for Anne. She has good insight. She told me when I met her at the ED, listen, I can see the big picture. I know I don't want to use, but I have an addicted brain, she said, so it's minute by minute with me right now. Thank you for your patience. I'll share a little bit more about Anne while I introduce the intervention, but as a spoiler alert, Anne has a Housing First voucher now. We are pursuing the next steps in housing with her. She started methadone maintenance. She has ID. Her benefits application is being reviewed. She has, it was not clear that any of this was possible just a couple months ago, and it wouldn't have been without her asking for the support when she was ready for it, and us showing up with her there in that moment. So how did we find Anne? We see her outside nearly every day, and we have received provider referrals for her before, but we initiated contact with her based on our integrated data, our daily review of hospitalizations, and our patient selection criteria that honors the whole patient so we can see complexity in the medical and social picture of a patient like Anne. Over the years, Dr. Brenner and his team built the infrastructure to make patient selection data-driven. All the healthcare utilization data from the 3 Camden healthcare systems are filtered as reports into our HIE, and they're reviewed by our triage specialists every morning, specifically for patient assignment to our care management initiatives team. If eligible, they're assigned to the team, and we get data daily, review it every morning, using the hospital EHRs, again, and the HIE, to review the medical and social notes and look for things in the record that suggest barriers to care. Some examples of this would be looking for notes in the medical record that say a patient is non-compliant or non-adherent, which indicates difficulty developing a good relationship with the provider, or something that might look like lack of social support, homelessness, or mental illness we also look for as well. We centralized our patient selection, and we called it triage, and we do this citywide. And in our patient selection process, we look at the whole population, so we're scanning all the utilization data, we screen for hospital utilization, and then we do a manual review of all the high utilizers for complexity. We assign engagement of patients when we believe that, that they can get better, that they can be healthier with our support in care management. And we have a continuous open dialogue about what we can and can't do for patients. So, for example, with Anne, we couldn't work with her when she only gave us 10 minutes at a time. But we could when she could get through paperwork filings and also longer conversations with us, just as an example. We also ask the patient when we meet them if they think they can get better with our help too. So it's not just that we think they can get better, but they must agree with us that they think they can get better too. And if they say yes, then we will engage at that point. Just to kind of give you more granularity in our patient selection process, this is one part of our triage process in which we look for complicated medication regimens, so people who have 5 or more medications. We also ensure that social and language barriers are considered in triage, and we look for social isolation. So we look for lack of social support. We review the full medical record to substantiate our decisions, and we really dive into the patient record. So our triage specialists are reading all the social notes, all the medical notes, just to look for things that might be barriers to access to care. Who we don't assign is often as important as who we do assign. So to this question of best practices and then practices we've tried in the past that haven't worked as well, if a patient has numerous resources to care, he may say yes to our services at bedside in the hospital, but we may not be able to add much value to what the patient already has built around himself. And so we're really looking for people who don't have social support and who have faced big barriers getting into healthcare. Our use of hospital data helps us engage people who simply may have fallen through the cracks before. So whereas previously, if we were using a referral approach from hospitals, we might find people who are difficult for providers to work with, but we might not find people who just aren't even showing up at all, other than at their inpatient admission. So through our patient selection, all eligible patients are assigned either to our 7-day pledge reconnection to primary care within 7 days of hospital utilization, or to our intensive community-based intervention. What happens when we do engage a patient? We consider many factors, and we've highlighted these on this slide here just to show that we prioritize honoring the whole person, meeting the patient where they're at, convening people and looking at systems that might be broken around a patient impacting care, also taking an everyday approach to refining our major interventions, which are our 7-day pledge and our intensive community-based care management initiative. We have dedicated teams for innovation to make sure that when parts of our interventions aren't working, we can test and try things out separately from outside the interventions. We use data to inspire action, and most importantly, we value strong people principles. Okay, pardon the pause here. So just as a kind of a basic formula, patients with significant medical complexity are engaged by the care team in an intervention that's grounded in 2 basic metrics. So our community-based care management team learned over the years that having simple metrics to measure itself by helps keep things grounded when things get complicated, which they always do. So we attempt a home visit within 3 days of discharge from the hospital for all patients, and a PCP visit like the 7-day pledge within 7 days of a hospital discharge. So our patients on the care management panel are part of the 7-day pledge as well. Again, we've learned it's really helpful to have basic measurable components of the intervention because things get so complicated, and this gives us a chance to step back and say, okay, have we done these 2 things? Have we met the patient in the home, and have we gotten the patient back to primary care? The rest of the work, which is nearly all the work, is the development and implementation of a care plan that's centered around each individual using a care philosophy, which we've developed over time and incorporates trauma-informed care, motivational interviewing, among other engagement methods. Just to emphasize again, we look at the whole person and assess all the domains in which they need help. When we started, we figured someone in the hospital may have healthcare as their first priority, but We quickly learned, though, that, so when we started out with the intervention, we learned that we thought, you know, if you're in the hospital, healthcare must be your first priority, right? But we learned housing or lack of income due to legal barriers may be top of mind for a patient, even one who's very, very ill. So we build the intervention based on where the patient is in their life. We build a rapport with the patient, and we learn about them by starting the conversation around his or her own goals, even when those don't necessarily align with what our goals might be for the patient. Our goals only trump the patient goals when safety is at stake. We constantly refine our intervention, and again, meeting the patient in the home, we learn a lot about the patient, seeing them in their own home environment, and we learn more about the barriers that they may experience, and we learn from them what their own goals are. We stay focused on the key components of our intervention and the care plan when things get overwhelming. And again, they almost always get overwhelming. As staff, we reflect on our engagement data for the 3-day home visit and the 7-day pledge. This keeps us grounded so that we can focus on all the complexity that comes with the patient. Additionally, we have consistent care planning meetings, complex case conference meetings to ensure plenty of opportunity to discuss patients and determine the difference between one patient struggling versus a patient typology we haven't quite mastered how to work with in our intervention yet. So we meet patients at their stage of change, and we learn a lot about them and their goals by visiting their home. Remember Anne again, who I talked about earlier? So she's been homeless for, sorry, I'm going to get in just a moment to this care management meeting slide, but leading up to that. So Anne's been homeless for 4 years, as I mentioned earlier. We met her in the hospital. Sometimes we meet her at a program site. Many of our patients experience homelessness, and our work with Anne kind of highlights our social work operations team. We built this team out of one of our innovation projects. Initially, we thought we better assign any patient with social work or behavioral health needs, like a referral, as an assignment to the social work team to work alone with that team. But that actually failed because our social work ops team wasn't as well versed on the physical medical side as the rest of the team, and the whole panel wasn't getting the support that it needed. So the team actually took a consulting framework, and so that now the social work team is available to the entire panel. The social work team manages our Housing First and other housing initiatives and works with all patients with housing instability. It manages behavioral health consults and also systemic social barriers. So to the point of this slide here, we also learn that we can't work with patients in isolation without trying to redirect systems toward patient-centered care for complex patients. We convene care management and social services staff across the city to improve care management. And Anne has worked very closely with our social works op team for ID to move forward with our housing through our Housing First program. And we can talk about patients like Anne at our monthly care management meetings to get feedback from citywide partners, to ask questions about, are there things that we're missing? Are there things that citywide partners may be missing with their patients that we can assist with? Additionally, we convene primary care providers and staff in a dinner series, and this builds community and acknowledges the hard work of change in healthcare and allows us to celebrate our citywide effort to bring all patients to primary care within 7 days of hospitalization through the 7-day pledge. So just to recap, we have 2 bread and butter interventions, our care management initiatives and the 7-day pledge. We have teams who make these interventions run all day long. We also have teams dedicated to innovation, and we've learned that we needed that because if we have our care management team engaging with patients through our standard intervention and through our intervention that follows our protocol, they don't have time to test working with other patients who have different needs than the ones that we've already made routine through our standard intervention. Currently, these small teams are working on deepening our learning around patients who are pregnant in the ACO, patients who struggle with addiction, and those patients who use the ED frequently. We use data every day to make decisions, excuse me, about patient engagement. We use it to inspire action and process improvement. We present daily, monthly to our providers and to the staff in the ACO. We also use data internally every single week and even every day, but formally every single week in our meetings to ensure consistent feedback loops and, again, continuous process improvement internally. It also allows us to take a bird's eye view. When things get overwhelming, we can look at our metrics and see how are we doing, what are the things that we could be doing differently, and it gives us a chance to step back, take a look, and try something new if what we're currently doing isn't working. But maybe one of the key points is that regardless of how well a patient fits into our core care management initiative protocols, we maintain strong people principles and we focus on patient-centered care. This gives us the agility to meet patients where they are when they're ready. And we have protocols and standards of care for efficiency and also to be able to scale and see more patients. We work hard to improve patient care, but we also work hard to support staff. We look for fatigue, overwhelm, and burnout, and we make room for fun. Like in this picture, if I had to guess, we're probably doing the Cupid Shuffle, which is something that you would commonly see around the Camden Coalition, if we just need to take a 10-minute break, regroup, and make sure that we're taking care of ourselves so that we can manage doing this very complex work in the community. So how does this impact Anne, or a patient like Anne? It means that although Anne is having a really rough time right now, she's making progress, and she knows we'll be there for her even if she's not making great progress, but wants to take small steps, as long as she wants to take those small steps together. Thank you.
Okay, great. Thanks, Molly. So at this time, if anybody has any questions, please enter them into the chat box. We already have a couple of great questions. The first one is from Debbie. The question is, what is your process for finding and working with hard-to-locate patients who do not have a consistent address or who are homeless?
Yeah, so that's a great question. Thanks for asking that. We find our patients typically through hospital utilization. So we work with numerous patients on our panel experience homelessness, and we are able to engage with them when they go into the hospital. Some patients don't have the chronic medical conditions to require an inpatient admission. In those cases, we would engage those patients through our innovation projects for ED high utilizer engagement, and we have now live communication with the ED departments and through data feeds to know when our patients who are experiencing homelessness are in the emergency department so we can meet them there.
And then our second question is from Linda. What are lessons learned about the staff-patient ratio needed for this type of engagement?
So this is a favored question, sort of finding that happy ratio. I almost put some numbers in here for you guys to look at around patient panel size and things like this, but I think what we've learned is there is definitely a sweet spot. So we've taken our panel way too big, and we can't actually engage with the patients fully and appropriately. And then we've had our panel too small, less than we can actually handle. There's not one ratio that works. A lot of it relates to what your team capacity is, what your experience level is, and also how well developed your intervention is at the time that you're engaging the patient. What I would say is that we focus strongly on being able to monitor and look for things like staff overwhelm and burnout, because if you're losing your staff, you're definitely losing your patients. So we focus on looking for indicators of overwhelm and burnout, and we look to, we definitely try to keep the panel as large as we possibly can.
I would say also that, Molly talked about the two different interventions that we have. So the care management initiatives, which is our really high-touch, community-based intervention, is one where there's just a lot of time that goes into relationship building and meeting the patient where they're at, spending time in the community, in the home. That's the panel that, that we really need to pay attention to that size because of how much time it takes to work with those patients. Our 7-day pledge is more of a light touch intervention where we're working to reconnect patients back to primary care after they've been in the hospital. So we can touch a lot more patients in that intervention. So it's also about designing kind of how intense is the intervention that you're trying to build.
Okay, Great. And then building off of that question, what type of training do you give your employees and what do you look for in hiring?
Yeah, those are also great questions. So we have over the years developed a standardized training process, and we train all of our staff on our what's called our coach care philosophy, and there's quite a bit of information available about that philosophy now, publicly available, and also we're happy to share it with you. So all of our staff goes through that training. Additionally, our staff goes and shadows more experienced staff for the first couple of weeks of their time with patients, and then we level up staff slowly with patient panel size. Again, we want to be looking for longevity. We want to be looking for the ability of a staff member to manage a patient panel over time. I hope that answers your question. There is a significant training process that has become more standard over time. In the beginning, it was not standard. It took time to build that up, and a lot of it was born out of our own care philosophy that we've developed that works with our systems, our data systems, our organizational culture, and we have standardized that, and we do ensure that all of our staff has that training. And in terms of what we look for in hiring, so we definitely are looking for people who are open to and capable of taking a harm reduction approach with patients. So we want to make sure that staff is, again, willing to take a patient-centered approach. Sometimes patients aren't in the same phase of change that we might wish they could be or that we think they should be based on the risks in their lives and the complexity that they experience. But we want to make sure that a staff can really build rapport with a patient quickly. But we're also looking for staff who can manage complexity and say, you know, wow, this is really an overwhelming patient case. I know I need to focus on these 2 or 3 things, and I'm going to avoid getting totally overwhelmed by the sort of disorganization that this patient is presenting to me. So we're looking for both of those things. We do actually, we often show a video called we call it the Insight video, but it's a video, it's available on YouTube. It's a video about a supervised injection site in Vancouver, British Columbia. You know, and again, that's just the video we use, but there are lots of YouTube videos and other publicly available videos that can help you sort of elicit conversation in group interviews or individual interviews to talk with people and get a sense of what is their approach? Are they taking a harm reduction approach? Does their approach match your organizational culture, and is that a good fit? So that's a sort of a tactic that we use, is to show a video.
And then the next question, I think a lot of folks have asked this. I've got a lot of organizations and communities that are doing this work and maybe starting from a different point. Are there any kind of worst practices or rookie mistakes that you'd be able to warn other communities kind of off of?
That's a fair question. I wish I could stave off any and all challenges and problems and failures, but actually I think that's how we learned. We've made so many mistakes. We have failed at working with patients. We have lost patients that we thought we were doing a great job with. We have, you know, we've had many struggles engaging patients and figuring out our own boundaries working with patients. And so I think what I would say is that, especially when the work is new and when it's overwhelming, it's really important to take care of yourself. I know it sounds kind of cliche, but this work can be pretty overwhelming, and just because you have boundaries with a patient or because you're establishing care protocols that you are starting with, it's okay to have those boundaries, and it's okay to say no, and it's okay to say we can't do that with you right now, or to establish with a patient, you know, look, we set up 2 meetings and you weren't there, and so I'm feeling frustrated. I'm feeling concerned that I might not be able to, meet you again, and how can we help you be there, et cetera. So establishing boundaries, and then knowing when a patient isn't engageable at that particular moment. So I think one of the big things that we've learned is that we don't chase after patients. We really try to assess, is the patient looking to work with us? Because that's when we're the most valuable. we're not that valuable when we are chasing after people. So, so that's been an important boundary for us.
I think that point, too, can sort of be extended to a lot of different areas of how we've sort of stood up a lot of our different parts of the intervention for the ACO. It's just this idea, it's like just remembering what we know about change management. So whether it's working with a patient or working with a practice or a community partner or even our own teams internally, just remembering to kind of listen and take stock of what's going on for people, what are people's different pain points, what are their agendas, and trying to design and work within that framework. So I think in the same way that we're listening to what a patient's goals are, when we stood up our work with the practices, for example, it was really important for us to listen to them about the barriers that they were seeing on a daily basis in doing work with their Medicaid population, and in trying to respond to that, and trying to, co-design with people that we needed to get the work off the ground. So I think a really big mistake is trying to kind of force an agenda or force the work when partners or patients aren't really ready for it or aren't on the same page.
And then also just to sort of, this is Molly again, and just to kind of take the flip side of that, I think another rookie mistake that we may have made in the past is that, when a patient hasn't been engageable, we have at times in the past said, okay, well, we're not going to engage with that person, ever again. And I think we're becoming much better now at being agile to the patient needs, so knowing when to say, this isn't the time to work with you, but Anne is a great example of a person who wasn't really engaging with us. And then when she was ready, we were available to her, and that meant all the world to her. We had the flexibility to meet her when she was actually in a moment of change, and could support her, but we didn't try to force that moment of change on her. That could have happened 2 months ago, could happen 2 years from now, and we want to be ready for that when it happens, but it's hard to do that. So the rookie mistake is not knowing that balance, but also being, forgiving with yourselves that it takes a long time to figure that out inside the context of your own organizational priorities and barriers, et cetera.
And the last question I see, so if anybody else has any questions, please type them into the chat box now before we get started on the next topic. But one last question, are there lessons from your work that are transferable to other less risky populations, such as in Medicare?
So we have a lot of patients who in our care management initiatives that are not technically ACO patients who are dually covered with Medicare as well, and they have lots of medical complexity. But inside the ACO, we have definitely, like Natasha said, we've built out this 7-day pledge, and that is a way for us to address any hospital utilization inside the ACO, even when the level of complexity isn't as high as some of the patients who would be eligible for our care management initiative. And that way, what we're doing is we have a citywide call effort to make sure that we're scheduling and managing transportation barriers for patients so that they can get back into primary care and hopefully address some of those things that cause the admission.
Okay, great. I don't see any further questions. If you do, please type them into the chat box now. With that, I think we'll get started with Natasha. She's going to talk to us about patient satisfaction surveys.
Cool. So I'm going to talk a little bit about patient satisfaction surveys. As many of you may know, this is actually a regulation. As New Jersey Medicaid ACOs, we are responsible for reporting on patient satisfaction. But I dropped the text in there just to show that the regulations aren't super specific about how to do this. So at the Coalition, we tried to see this regulation as an opportunity to collect data about our patient population and to start a high-quality conversation with our partners across the city. So we could have tried to use the data that practices were already collecting on patient satisfaction. So most of our primary care practices were already doing the HCAP survey or the Press-Ganey survey or had their own, but this wasn't consistent across the city. So we wanted to see if we could use this regulation as an opportunity to create a standard patient sat tool that we could use to sort of compare our practices to each other and across the ACO as a whole. So this was really an opportunity. And as we began down the path, one of the things, just to highlight off the bat, one of these worst practices we've been talking about, or a place that seemed to trip us up, was that whenever we tried to get too scientific or think about this as kind of a research problem, we ended up making things far too complex and difficult. So one best practice that we've identified when we're thinking about patient satisfaction is to remember that this is really a quality improvement exercise. This isn't an effort to reach statistical significance. So that's just kind of the framing that we took going into this process. So we started by working with our ACO quality committee to start designing the survey. So we brought our partners. Our quality committee is mostly made up of members of our primary care practices and other community-based organizations. And we had them all bring in all of the different survey tools that they were using in their organizations to measure patient satisfaction. And they worked together to put those surveys together and create a new tool that sort of merged their different tools together. One of the things we did early on was that was kind of a mistake was that we didn't, the first year we didn't end up testing the survey on patients first. So the first year that we did it, we got some feedback that some of the questions weren't worded clearly. So that was when we started to leverage our Community Advisory Council as well. So between the two committees, we had sort of the ACO Quality Committee thinking about what was the content that should go into the survey, but then our Community Advisory Council really helped us frame the language and word the survey so that it was friendly to our patient population. We also have created a rhythm where we're refining the instrument every year. So we do want to be able to compare the results year after year because we want to see the trend. But we do make minor tweaks of the instrument every year so that we can incorporate the feedback that we get from the folks who are administering the survey and really listen to the patients as well about what they're telling us on the survey. So here at the Coalition, the way that we activated our patient satisfaction survey was actually through a summer internship program where we brought in, we call them summer associates, but really they're interns. We just like to give them sort of a fancier title just to make it a little bit feel more professional. And so we brought in a team of interns to administer the patient satisfaction survey in the practice waiting rooms. So this definitely can seem like a lot of coordination and effort. There's always the idea that you can kind of administer these surveys over the phone or take on sort of a lighter touch approach to this. But this solution made sense for our organization for a number of reasons. So firstly, the Coalition really has a culture of service learning, and we believe in the value of exposing young people to working in the healthcare sector in Camden. And we get a lot of interest from students who want to get involved with the Coalition, oftentimes for a summer internship. So this is a good place to kind of funnel folks who were interested in getting some exposure to the Coalition and having a discrete project. And we also knew that from our past experiences, administering the survey telephonically would probably yield low results. So we've definitely seen time and time again across all of our interventions in Camden that when we can meet with patients face-to-face versus over the phone, we just have a lot more success. So I would say that standing up the summer internship program around the patient satisfaction surveys would require about a 25% to 30% full-time equivalent to really get this off the ground, starting in April or May to do recruitment, and then through the end of the summer. So it does require sort of a dedicated project manager. And the way we did this was we recruited from local schools and those that we have relationships with. So for example, we have an alum over at Cooper Hospital who connected us with the Shepherd interns. So they were coming to us from Washington and Lee University, and since then that's expanded. We're getting them from other schools as well. In the first year, we were able to basically run the program with, all the interns came with their own funding from their schools, but that actually limited the number of folks that we could get locally from Camden. So now we do a mix of funding from universities, but also we offer stipends to some of our interns. And then we've done it, some years we have both medical and undergraduate students. One year we had just undergrads. I think we're seeing that when we have the mix of med students and undergrads, it's a good balance to have some of the more experienced folks on board. but really it can work either way. And then there's a number of examples of different programs that we can circulate afterwards, but Rutgers School of Public Health, for example, has a Bridging the Gaps internship program, which is a great place to recruit from. And then we've learned over the years that we should really think about that training, that orientation and training for the summer associates, because if we do a good job in that first week of giving them all the tools and information that they need, they really can sort of run the project on their own, definitely with oversight and supervision, but because there's a team of them, they're able to do a lot of problem solving together and kind of move the work forward with, I would say, less supervision than if you kind of skimp on that orientation and training in the beginning. And then again, what's nice about the scope of the project is that it's super clear. It's, they get here, they're doing data collection, then they're doing data entry, and they're finishing out the summer with data analysis and reporting. So just to reiterate, some of the other benefits of doing the patient sat survey with this team of interns was that we really deployed them across all of the primary care practices in the city. And like I said, here in Camden, we have 12 primary care practices. And so these students really get kind of a system-wide perspective on healthcare delivery, in particular primary care. They get to be out and about. They get to interact with patients when they're doing the survey. So they get to be in the community, but then towards the end of the summer, they're also exposed to the data and the analysis work. And the team tends to self-select into the tasks that they find most fulfilling. So there's a certain point at which there's overlap of when we're doing data collection and data analysis at the same time, and the team kind of naturally just goes towards the tasks that they enjoy. What has worked well for us is that every year when the interns get here, the first thing they do is they work together to create a work plan. They set up their metrics, and they get to know all of the champions in our primary care offices. And then they also end up serving as another engagement tool for our practices. So when they're out in the field and they're talking with our practice staff and they're observing things in the waiting room, that they come back, they bring that information to us, and it gives us another kind of touch point and engagement point to work directly with our practices. So for survey collection, we decided to administer our surveys in the primary care setting. We chose this avenue because we have those 12 practices and we have strong relationships with all of them. This isn't the only setting that you could choose to administer the survey, and in some sense it might be somewhat unrepresentative of the ACO because we end up surveying people that who make it to their primary care practice. So other options are to administer the surveys in the community or in the emergency room. This would require tailoring the survey more to collect explicit information about primary care and whether the patient has a primary care provider and what their barriers are to accessing that provider. But it solves the problem of, we sometimes think about the fact that we're missing the non-customer by just sampling within the primary care setting. So we administer the survey in the waiting room. We do that before the patient is seen by the provider, and so they're being asked questions not about that specific visit, but about their general relationship with primary care. And we offer it to all patients in the waiting room, not just Medicaid patients. So we do ask on the survey what their insurance status is, but we offer it to everybody. Our summer associates bring healthy snacks, and again, those are offered to everyone. We decided not to offer incentives. That was an idea that we toyed with in the beginning, but we decided not to do that because we worried that that might influence their responses to be more positive. So the healthy, they just bring kind of waters and pretzels and other healthy snacks that are, again, available to everyone, not just if folks opt in for the survey. We offer the survey in Spanish and English, and we offer to do the survey verbally if the patient desires, so that can help us address any literacy issues. And then finally, we've grown our target numbers over time. So in the first year, we had 4 summer associates, and they collected 350 surveys, and that was just kind of our learning year. And since then, our goal has been 700 surveys minimum. This year, we actually have 8 associates on board, and they are aiming to collect 800 surveys. So the data analysis portion it's pretty simple, and so we have we've been pretty successful with the summer associates completing the majority of the analysis themselves, but we've seen that they do need strong support from our data analytics team, just so that they don't go down the wrong path. And that is partly because we don't require the summer associates to have any prior data analysis experience. That could be something you could easily tweak and say that you want someone who kind of has some experience doing this. But we've really, it's been fun to have summer associates kind of learn that skill while they're here. One of the things in terms of worst practice, when we, the first year, probably the first and second year, we didn't do as good of a job framing the data analysis piece for the associates. In the beginning, we were kind of stressed out about the target number of how many surveys we had to collect, so we really focused on the data collection, and we focused our training and our just sort of our time with the summer associates in the beginning on that piece of it. But we found that it really helps to frame the whole arc of the project for the summer associates from the beginning, because it just allows them to kind of get into the data analysis earlier and to be more effective with that work. So it's helpful to kind of introduce the work early on in the summer with the data analysis. Cool, so I'm going to move into a little bit of the actual data. So this is our citywide data from the first year that we administered it in 2014. So you'll see there are 10 questions here, and this is what you're seeing, that there's kind of a summary tag of what the question was asking about, and then you're seeing the percentage of 4s and 5s, so 4 being satisfied and 5 being very satisfied. So our goal on each of these questions was 80%. We wanted 80% of patients to respond that they were satisfied or very satisfied in each of these categories. So the clear story that kind of came out of this first year of analysis was that the top 4 questions you can see had much lower scores than the bottom 6. And if you look at the top questions, these are the ones that really have to do with access. So how easy is it to reach the practice by phone to schedule an appointment? How easy is it, or how often are you getting a response to messages left after hours? So, and then the bottom 6 questions are more about the patient's satisfaction once they arrive at the office and are in the exam room with the patient. So this gave us kind of a clear story that we were able to use when we talked with our primary care practices about working to improve access. So it was easier to have this conversation when talking about the data as a common trend across the city rather than pointing fingers at individual practices. So we could say, as a city, we seem to struggle with access. But on the flip side, we were also able to give positive feedback to our practices by saying, in general, our patients are satisfied once they arrive at the office and get into the exam room with their provider. So these are a couple of qualitative lessons that we learned, and some of the questions that we asked just around general barriers to accessing primary care. So the one on the left, what barriers make it difficult for you to visit your primary care provider, was actually, that was like a multiple choice question where they could check off as many of those answers that applied to them. And you can see that question, and this is something that was interesting in the process of developing the survey, does not have an option for wait time. And that was because some of our providers who are on our quality committee didn't feel comfortable specifically putting wait time in the survey. I think there was some sense of like knowing that there was going to be some negative feedback about wait time. So that's kind of just one of the things to be careful of when you engage in this collective process of designing a survey with your stakeholders. There are kind of moments like that there might be anxiety about certain questions, et cetera. So we asked that closed-ended question with the options, but then the yellow graph actually is our open-ended question. So this was when we said what could be done differently to make your experience at this doctor's office better. We let them write in their answer, and that's our summer associates went through and tagged the answers to those questions to each of these categories, and there you can see that reducing wait time really did come out. So there's some power in the design of the survey based on what you put into the closed-ended questions and what you can really elicit from those open-ended questions. So this data is definitely helpful in starting a conversation with our providers. In a lot of cases, people kind of already have a sense anecdotally that these are the barriers that folks are facing, but it does have the potential to help us create a rallying cry in the city around particular issues. So this slide shows just an example of one of our detailed practice reports. So in these reports, we actually break out the data for each question, and we provide sample. I think we actually try to provide all of the written quotes from the surveys, and these are done on a practice-specific basis. And then we provide this whole detailed report back to the practices. We use these reports to activate a conversation about quality improvement work within the practice. And sometimes we've just found that it's useful to have an external facilitator, so we at the Coalition are coming in externally to the practice with external data that's been collected by our team. This can really provide a great platform to start thinking about PDSA work. It sometimes can give middle management a tool to raise the issue to leadership. So sometimes we've found that it's helpful to be able to come in as an external participant and help facilitate that conversation. And then finally, our patient satisfaction surveys that we do in person in the waiting rooms happen over the summer, but we also have an online feedback portal where anyone really can enter feedback about the ACO. So that can be patients, but it can also be practice staff or hospital staff or our own care teams on behalf of a patient. So what we've seen is that a lot of our care teams use this tool to report things that they've seen in the practices or in the hospital that they kind of want addressed. We have blasted out the link through, we have little business cards with the link in all of our practices, but we haven't seen too much use of the tool by patients yet. So we're hoping to kind of increase knowledge of this tool across the city. But we do, like I said, we do get input from staff, both from our own team and then from the community. And all of these complaints get put into a summary report quarterly, and those go in front of our quality committee for the quality committee to talk about and discuss whether there needs to be any action taken. Cool, so that's all of the major content I was going to go through, but we have a lot of resources that we are planning to send out after this session about kind of just how we stood up the program, how we recruited people. We can send multiple versions of the survey that we've used, and then we can also show you how we activated our feedback portal and some examples of the reports that we give out to practices. Cool, thank you.
Okay, great. So at this time, if anybody has any questions, either for Molly or Natasha, please enter them into the chat box. And I think while we're hanging on a sec to see if folks have questions, I actually had one of my own. If just on the surveys that you do in the practices, have you run into any other literacy issues, and if so, how did you address them? Like if you had a deaf patient or if you had a patient that was not English or Spanish speaking. I know, for example, up in Patterson, we have a lot of different languages being spoken. So any other issues, and how did you address them?
Yeah, so I think that unfortunately at this point, how we've addressed that is that we have our English and our Spanish-speaking summer associates, and unfortunately we're limited to being able to survey patients that speak those two languages. If they can't fill it out on their own, we do try to do it interview style. One other thing that came up was a larger text, like a larger font. We've definitely, we have a few versions of surveys with larger text for people who can't see very well, but no, we haven't really been able to address those other barriers. I would say that just in the same way that we've recruited, the first year we actually didn't think to recruit someone who spoke Spanish, but we got lucky, and one person was a fluent Spanish speaker. We dodged a bullet with that because that's definitely a huge portion of our patient population. So I think if you plan for things like that, if you plan for a language that you know is a common one, you can try to recruit someone who can help with that. But yeah, we haven't addressed sort of the other disability issues.
And so at this time, if anybody has any other questions, please enter them into the chat box, and we'll hang on just a second to see if there are any additional questions. And also wanted to, again, mention the Nicholson Foundation, who generously supported the QI Collaborative's work with all of the ACOs, as well as these training sessions. So I don't see any other questions being asked at this time. So we are going to, again, have this webinar with the recording available for everyone with some additional materials after the webinar. And if anybody has any questions, we would be happy to answer them after the fact as well. So a big thank you again to the Nicholson Foundation, and then also to Molly and Natasha from the Camden Coalition of Healthcare Providers for our training today. And thanks everybody for joining us.